Tack så mycket Eva Nordin, tack Autism och Aspergerförbundet och UR för introduktionen. Varmt välkomna till Fokus på autism 2014, världsautismdagen. Vi kommer att ha en Globen som lyser blå ikväll. Vi kommer att ha Tivoli, Gröna Lund som lyser blå ikväll. Och även jag och några få andra lyser också ganska blå idag. Vi har ett ganska tajt och spännande program framför oss. Vi börjar med keynotes som sitter här framme, som kommer också förstå lite mer vad jag kommer att prata eftersom jag kommer byta till engelska så småningom. Och sen har vi en hel del massa svenska seminarier som börjar imorgon. Och sen fortsätter vi på fredag där vi har försökt att dammsuga allt som pågår inom Sverige när det gäller framförallt forskningen inom området. Det är så här att det är väldigt många som har hjälpt till att det blir verklighet med Fokus på autism denna år. Det är mina medarbetare på Kind och sen finns det en hel del, framförallt Monica Rydén-Aulin som sitter här framme som ni har träffat och många av er har haft kontakt med. Och sen finns det många medarrangörer, framförallt habilitering och hälsa i Stockholm. Vi har BUP, vi har specialpedagogiken och en himla massa brukarorganisationerna. Om ni vill veta exakt vilka det är, får ni titta i den här lilla boken som jag har kring halsen. Sen tycker jag att efter den här dagen att vi kan samlas alla här ute och mingla lite och byta lite tankar och inspirera varandra. Och eftersom det brukar vara så att man ligger efter i tiden, vi är ungefär ganska bra i tiden, ska vi också försöka att se till att det förblir så här. Så jag tänkte att vi går i medias res på en gång och jag kommer byta till engelska nu. So I now switch to English so that you can understand what I'm talking about. And we have the first presentation, which is by Chris Oliver. And Chris Oliver is a professor in Birmingham in UK. And he's also director of the Cerebra Centre for Neurodevelopmental Disorders. And he's a psychologist with special focus on neurodevelopmental disorders and syndromes, particularly in combination with intellectual disabilities. And here he also has a focus on challenging behaviours, which we know are very important in autism. And so that's exactly what he's going to talk about. And I will keep my fingers crossed for Lewin Football Club in the future, because I know that's very important for you. So welcome to Stockholm.
Thank you. Thank you very much, and thank you indeed for the invite to come and speak at the conference, and also to come to the beautiful city of Stockholm. It's been a real joy to come along here. I'm going to speak about challenging behaviours, and I'll say more precisely what I mean by those in a second. And I'm going to focus on the behaviours we see in some genetic syndromes, primarily because this gives us, or has given us, a better way of understanding the causes of challenging behaviour and being able to broaden the models that we already have. And there are certainly implications for the behaviours that we see in autism spectrum disorders arising from that research. So I'll just mention the behaviours of interest. So I'm primarily interested in the behaviours we see in people with more severe intellectual disability, behaviours such as aggression to others, self-injury in particular. We see self-injury in about 50% of people with autism spectrum disorder, and other problem behaviours such as destroying the environment. These are very common in people with severe intellectual disability. We know there are some person characteristics that predict both severity and presence of these behaviours. And these can be considered risk markers because we can identify these often before the behaviour emerges in the early teens, for example. We know little about how chronic or how long-standing these behaviours are, but in the UK we followed up a sample of people that I saw in the mid-1980s who were showing self-injury. And I'm sorry to say that 20 years later, 80% of those people were still showing self-injury. And this figure has turned up, this 80% estimate, of persistent has turned up in a number of studies over a number of time periods. So I think what we know about these behaviours is if they are there, they will be there for many, many years. And I think this adds weight to the importance of early intervention. I think it's very easy to underestimate both the human and economic costs of these behaviours, not just the pain, discomfort that the individual will feel as a result of these behaviours, but things like relationship breakdown when it means moving people from their home environment, compromised quality of life, and so on. And the economic costs are not well documented in the UK, but it would not be unusual for us to see very significant single-person services at very significant cost over many years. In the UK, at least, we do not see high levels of appropriate clinical intervention. This doesn't mean there isn't a good intervention literature, but it does mean that people will not necessarily be in receipt of those interventions. And the trend in the UK and the USA, I think, in other literatures, has been to identify the causes of these behaviours, things like self-injury and aggression, as located within the person's environment, within an operant learning theory framework. That's been the dominant view, and to some extent that has relegated the importance of personal characteristics. And it's that which I want to focus on today, because I think that we need to attend both to the immediate environment through behaviour analytic interventions, but also to person characteristics. And I really want to highlight that issue. In the UK, I think elsewhere, we've seen models of the behaviour call upon the local environment as the causal mechanism through operant learning theory. And I think that's led us to put more emphasis on the characteristics of carers who have immediate contact with people, and then on the level of, for example, staffing levels, roles and responsibilities, expectation, and then again on macro system variables and how much funding, for example, we might put into these services. And that model has dominated, and it's translated into policy, certainly in the UK. But it means that the person characteristics are given very little attention. And I think there's very good reason for wanting to attend to these person characteristics. And one of these characteristics is the cause of intellectual disability. And so I'm going to explore the implications of thinking about what are the causes of someone's intellectual disability, particularly from the point of view of having a genetic syndrome. And then I want to explore how that might help us refine our descriptions of psychological, psychiatric disorder, helps us build models of challenging behaviour, and then just to finish on something around a developmental perspective. So the purpose of the exercise really is to take a look at some of these individual syndromes, because they can tell us a great deal about the difficulties that all people with intellectual disability and autism spectrum disorder experience. And it does help us build some causal models. So I know there's too much detail on this slide, and that's the point. The point is that there are numerous individual syndromes associated with intellectual disability. There are any number of syndromes, and the number is growing. In the UK, there's a large-scale project identifying microdeletions associated with intellectual disability. But the point arising from this is that any one of these individual syndromes may have a different presentation from other people who don't have that same syndrome, and the group of people that we label, if you like, as having an intellectual disability or autism spectrum disorder. So I'm going to make the argument that there are meaningful differences. And on the one hand, one may argue, well, these syndromes are very rare, but they are likely to account for significant proportions across the total population of people with intellectual disability. So they'll be individually rare, but they will not be uncommon amongst the group of people with intellectual disability. So these are 7 syndromes that we've focused on in our research. And in each of these syndromes, it helps us to focus on one particular aspect of behaviour and understand how that behaviour has a cause rooted at a number of levels. And I'll touch on those in a second. So you can ask the question, well, does etiology, does cause of intellectual disability matter for behaviours of clinical significance? And I just want to develop that argument. So if we look at the prevalence of behaviours that we would all acknowledge of being of clinical significance, then the prevalence varies systematically with the cause of intellectual disability. So on the left of this chart, you have a heterogeneous group of people with intellectual disability showing self-injury around prevalence of around 25%. And you'll see that figure replicated in a number of studies. Then as we look across, Angelman Syndrome, Cri-du-Chat, Cornelia, Delange, Fragile X, Prader-Willi, Lowe and Smith-Magenis, you can see varying levels of self-injury approaching 100% in Smith-Magenis syndrome. And then we can calculate odds ratios or risk ratios for that individual syndrome. And so for Cornelia Delange syndrome, you are 6.5 times more likely to show self-injury than if you don't have that syndrome. The importance of that for early intervention is it tells us about the weight of that risk. If you do the same for aggression, there are 2 things to note. One is the same syndromes do not appear to have the same high levels. So actually, it is only in Angelman syndrome and Smith-Magenis where we see significantly higher levels of aggression. And these behaviours segregate. So you are significantly more likely to show aggression if you have Angelman's, and you are less likely to show self-injury. And there's the opposite relationship for Cornelia Delange. And the point of this is that these behaviours are not clustering. So when we use the term challenging behaviour, we have to start being very careful. And I think it's time to stop using that term, actually, and start to focus more on the precise nature of the behaviours, because there is growing evidence that there is difference, meaningful difference between these behaviours. But the point to take from this is that etiology matters with regard to your risk and your form of behaviour. So this is a busy slide, but it shows us something that I think we've all known. So a number of syndromes from Fragile X, Cornelia Delange, Lowe, and so on. And then some microdeletions that are a bit less common, 1p36, a couple of... And then on the right-hand side, people with Down syndrome. And here in some surveys, we've simply said on the SCQ, a screening measure for autism, what's the prevalence of autism spectrum disorder and autism? I'm not arguing that this is autism spectrum disorder or autism. On the screening questionnaire, what proportion of people cross the threshold? And just to orient you, for Down syndrome, that's around 8% with a diagnosis crossing the diagnostic threshold. For autism, a figure you see replicated in a number of studies, and then in Fragile X, around 50%. But you can see the significant difference across all of these groups. So clearly, the etiology of your intellectual disability matters in whether you cross the threshold for autism or autism spectrum disorder or not. Whether the autism and autism spectrum disorder is the same as that which we see in idiopathic autism is a different question. But the point is that people would cross the threshold at varying levels. So let's just delve a bit further and ask the question, within the triad of impairments, does each component of the triad of impairments contribute to the same degree to the diagnosis of autism across the different syndromes? And the answer is it doesn't. In other words, the triad segregates to some extent in these syndromes. So in Fragile X syndrome, you can see a significant contribution to the diagnosis of autism coming from repetitive behaviour, whereas in Cornelia Delange syndrome, that is not the case. And these syndromes, don't forget, have comparable levels of the diagnosis of autism or autism spectrum disorder. And so we can kind of extend the argument and understand now that even if you are crossing the threshold at the level of triad of impairments, you cross the threshold for different reasons. Interestingly, it's a brief digression. You can make a similar argument for ADHD-type characteristics. So in Fragile X syndrome, it's the level of overactivity which contributes more to two of the components of ADHD. And in Smith-Magenis syndrome, it's impulsivity as opposed to overactivity. So in other words, even within the diagnostic criteria for ADHD, the components again segregate. Just to take that a little bit further, let's just focus on repetitive behaviour within these groups, forgetting the other components of the triad of impairments. And here you have around 19 different behaviours that we would label as repetitive behaviours. It doesn't matter too much what they are, but up around here you have stereotype behaviours. These are tidying, hoarding, rituals, lining up, and then these are more verbal behaviours. And what matters here is not what the precise behaviours are, it's going to be the overall pattern of these repetitive behaviours in different syndromes. And so this gives us a benchmark of autism spectrum disorder. There you are. So you can copy this down. These are the individual syndromes of heterogeneous intellectual disability, Angelman Syndrome, Lowe Syndrome, Prader-Willi, Fragile X, Cornelia, Delange, Cree-Duchenne, Smith-Magenis. But the point is, just when you look at that image, you can see that the repetitive behaviours differ significantly across these groups. So some look very similar. In the middle there, Fragile X syndrome looks fairly similar to autism spectrum disorder. But look at Angelman syndrome, a completely different profile. And note a recent publication within the last month, again arguing that there are very high levels of autism in Angelman syndrome, which I think is very contentious. But you can see there, the pattern of repetitive behaviour is strikingly different from any other syndrome. And then more interestingly, in Prader-Willi syndrome and Cree-Duchenne syndrome, note again the segregation of the repetitive behaviours. So there are only a few behaviours which feature prominently in these syndromes and others drop away. And so that even within the segregation of the triad of impairments, within one impairment, the behaviours segregate even more. And that shows that there's enormous diversity in these in the behavioural presentation. So I hope that by this stage I've shown you that in the genetic syndromes that etiology matters. There's gross difference, if you like, with diagnostic levels of autism, but there are also some subtle differences within the triad of impairments, for example. Let's just take that a step further, because I think one of the growing areas of interest is the diagnosis of autism within the individual syndromes, with the implications for whether some interventions may be effective. So I'm going to focus on Cornelia Delange syndrome because that's where most of our research has been, but I think the principle can extend across syndromes. And what we're interested in is the presentation of autism spectrum disorder in a high-risk syndrome the same as that seen in other syndromes? And we're just going to refine this question a bit more and explore the implications. One of the reasons for our interest in this syndrome is now that 3 genes have been identified and more are in the process of being identified, we are seeing people with a much milder presentation than used to be the case. And there, in that group of people, the autism spectrum disorder type problems become more prominent. So you can just ask the question, well, is this just associated with degree of intellectual disability? And the answer is no. So if you compare people with Cornelia Delange with people with Cree-Duchenne syndrome, so you've got a similar expressive language problem, you match for degree of disability, gender, you match for wheelchair use, some of the important variables, you still get a higher prevalence in Cornelia Delange. If you compare to a group of people of heterogeneous intellectual disability, at the bottom you see severe autism. This is from the CARS in about 30% of people with Cornelia Delange, 7% of the contrast group. So clearly intellectual disability alone does not account for this difference when you carefully match. And here again is this striking finding, looking across the triad of impairments on the SCQ. This is a group of people with autism. This is a group with Fragile X. Everyone in the 3 cohorts are scoring above the ASD cutoff on the SCQ, so they're all scoring above. But the contribution, again, to the scoring from different components of the triad, it segregates. So the Cornelia Delange group, it's a repetitive behaviour, is not contributing, something we reported earlier. But let's just take that one step further. Again, a bit of a complicated graph, but these are ADOS domains. So here we've scored people with Cornelia Delange syndrome on the ADOS, and a group of people with autism spectrum disorder, again matched for intellectual disability, receptive language, and so on. So we have contrast groups, or matched contrast group. And what's interesting here is that in some respects, the overlap between the people with Cornelia Delange and autism spectrum disorder is very clear. So when you look, for example, at pointing, shared pointing, then there is no difference. And you look at 1 or 2 other behaviours, range of facial expression and so on, no difference. But there and here, you have very significant group differences. So again, even within the domains, some of the social behaviours are segregating. And what's interesting is that sensory interests are not really very evident in Cornelia Delange. We have rarely seen these. And eye contact does not appear to be impaired in Cornelia Delange syndrome, certainly by the ADOS, and that's certainly my clinical experience. And I think that's a very interesting difference. But in that group, you do see higher levels of social anxiety than in an autism spectrum disorder group, and you see selective mutism in particular. And when you observe people in the ADOS, you can see this social anxiety emerging. So it may well be that the social anxiety is contributing to the ASD score, but not necessarily in the way that you'd want it to, as it were. And this appears to emerge with age. So the descriptions we have from parents, it's very clear that the children, when they are much younger, are much more sociable, but as they become older, they become more socially anxious and tend to withdraw more from social interactions. So the developmental trajectory in Cornelia Delange for this social anxiety is probably different from that which we would see in, for example, autism spectrum disorder. So this is a good example, I think, of where a different kind of disorder, in this case probably a social anxiety, is contributing to the way people are scoring on the measures. Just to pursue this story, because I'll finish on this at the end of the talk, is if you compare people with Cornelia Delange with people with Down syndrome, and then you vary the level of social demand on them, then people with Cornelia Delange speak much less. They're certainly showing this selective mutism. What's interesting in the Cornelia Delange group is if you take measures of executive function, things like inhibition, attention shifting, working memory, planning, organising, this predicts the extent to which they will engage in social interaction and the amount of time they'll spend speaking to people, but that's not the case in the contrast group in Down syndrome. So the reason we think this is interesting is that it may be that the selective mutism, social anxiety that can trigger scores on the ADOS and give an autistic-like presentation actually has a very different route to that we might see in autism, and it actually may be related to executive function problems. And then if we pursue this story, we've started to do eye tracking studies in children with autism versus children with Cornelia Delange syndrome. And at present, we don't see a difference between the children with Cornelia Delange syndrome and typically developing children in where they look to take information from the face. And this is true both in these static images and in moving images of social situations. So in other words, even though we have a group who are scoring at quite a high level on autism measures, the question of whether the behaviours are the same as those we see in idiopathic autism, or the roots of those behaviours, is an open one. Just want to give you one other example. I mentioned earlier on that a number of reports describe very high levels of autism in Angelman Syndrome. This syndrome is characterised by profound to severe intellectual disability, inability to speak in nearly everybody, and an ataxic gait. But the other thing it's characterised by is very, very high levels of sociability and seeking out social contact. And so these are studies in which we compared, in a socially competitive setting, the amount to which children with Angelman syndrome sought out adult attention in comparison to their peers in the classroom. And it's significantly higher. They spend much more time engaging with adults. And the point of this story is this, that this young woman with Angelman syndrome is looking at one of our research workers, and then there's another photo looking at another research worker. In many children with Angelman syndrome, gaining eye contact is an extremely strong motivator. People will seek out eye contact, and you can see here she's ducking down slightly in order to gain the eye contact. Now you can imagine that if you were assessing for shared attention, joint attention in an ADOS, then you can imagine that this striving to gain the eye contact would interfere with the shared attention, a skill that may actually be evident but not shown because a different kind of motivation suppresses it. So the point I'm making there is that, again, in another syndrome, you could have a different reason for the behavioural presentation when assessing for autism. So I hope I've shown you that etiology matters in terms of the behavioural presentation. I want now to try and build some of these causal models of challenging behaviour, and in particular to show you why knowing something about the syndrome might be important, and then explore the implications for conditions like autism spectrum disorder. One of the things that we've become interested in is self-injurious behaviour and pain as a possible cause of self-injurious behaviour. And as someone who started from an operant framework of understanding this behaviour to be learned as a communicative behaviour, I've drifted much more towards, as a clinician, wanting to look at pain as a potential cause of self-injury when I first am assessing children and adults. This is a very difficult area, because you can imagine in non-communicative children who cannot label their pain, their experience of pain may be very different, and then cannot communicate their pain. Trying to get valid assessment of whether a child is in pain is very, very difficult. There are some measures I've mentioned here. The FLAC is an observational measure. FLAC stands for face, legs, activity, consolability, crying. The non-communicating child pain checklist is a good measure, and the QABF is a measure of function of self-injury or aggression, but it does have a pain subscale. And we've been using some of these measures to look at pain as a correlate, at least, of self-injury in children with a number of syndromes. And the syndrome of interest here is Cornelia Delange syndrome. And in this syndrome, you see very, very high levels of gastrointestinal disorder, and you see very high levels of reflux. Very painful reflux with scarring of the esophagus, and a lot of pain behaviours associated with that. And we've developed a measure of reflux based on what parents tell us happens alongside the reflux, and then the behaviours that disappear after intervention, either from medication or surgery. And some of these behaviours are things like drinking excessively first thing in the morning because the reflux is worse at night, teeth grinding, scratching around the throat, scratching on the chest. And if you look at the group of people with Cornelia Delange showing self-injury, they have a significantly higher score on measures of the behavioural indicators of reflux than the group not showing self-injury. And that's very significant, I think. Secondly, we can ask the question, now we've looked at a high-risk group, we can ask a question, if you just take a group of children in a school with intellectual disability, do you see more pain behaviours in those showing the challenging behaviour than those not? And again, if you take a measure like the FLAC, yes, you do. These levels are significantly higher in the group showing aggression or self-injury. And you can ask a different question, which is, let's take another high-risk syndrome, in this case tuberous sclerosis complex, in which you would see high levels of pain associated with both kidney disorders, but also tumours in the brain. And again, if you ask the question in those showing self-injury versus not, do you see more pain behaviours? Again, the answer is yes. And we have to be careful here because, of course, you will have some pain resulting from self-injury, but many of the problems, the health problems that are reported in people are not those that you would expect to result from self-injury. Finally, we took this idea into the autism spectrum disorder group and simply said, in children with autism, are you more likely to have health problems if you show self-injury? And the answer is yes. And again, you have to be careful of causal direction, but most of the health problems that were reported were things like tooth decay, reflux, and middle ear infections. These are not things that we would expect to be the result of self-injury. And finally, and I think these are very early days, but when we use the measure of reflux to look at people with autism spectrum disorder showing self-injury versus not, then those who are showing 5 signs of reflux, around 65% were showing self-injury versus around 25% in those who are not showing signs of reflux. So this is, you can see we've had to do a number of different ways of doing this, and the obvious trial is the one we're doing now, which is to intervene, to have a medical intervention for the health problem and see if the self-injury decreases. That's actually probably the only way you can do this. But I think there's enough evidence for us to think, first of all, that in non-communicating children, pain can be a significant cause of things like self-injury and aggression. And that should be high up our list of things that we look at first. So just to go back to does etiology matter, in this graph you can see a comparison of 3 syndromes, Angelman's, Cornelia Delange and Cri-du-Chat. And I've mentioned Angelman's already and Cornelia Delange. And when you just use the QABF, what you see is that pain is more associated with challenging behaviour in the CDLS group than the other 2 groups who are matched for age, gender, degree of disability. So it does appear that the cause of these behaviours will differ across syndromes. And I'm not suggesting then that we treat all of the children with that syndrome in the same way, but our list of priorities for those children will differ depending on the syndrome. And we may more aggressively examine potential causes of pain in some groups than in others. We may think the ethical concern of those assessments is outweighed by the possible gains. So I've covered there how in a couple of syndromes, in tuberous sclerosis complex and in Cornelia Delange, that the physical disorder was important. And so this would always lead me now, when we become involved with new syndromes, the first thing I do is go and check the physical characteristics associated with those syndromes. Are there particular painful conditions that I should be aware of as a psychologist? I want to switch track now and look at motivation. And this is where, within different syndromes, there might be a strong motivation to seek out a particular stimulus that may lead to challenging behaviour. The best example we know of this is in Prader-Willi syndrome, where people may have impaired satiety, constantly feel hungry, and then difficulties around food-seeking behaviours are prominent. But the example I'll give you now is about Angelman syndrome. So I've already mentioned in Angelman syndrome that we see significantly higher levels of aggression in the children, 3 times more likely than we'd expect by chance. And we see very high levels of excessive sociability. And this is well documented now in the literature. So if this is the case, then if we adopt an operant framework, it may be that there is a phenotype-environment interaction. So it may be that if you conduct experimental functional analyses in which we systematically manipulate the environment, that we might expose the child to a highly motivating situation whereby the challenging behaviour is expressed because it's been rewarded in the past by the stimulus that they're seeking out. So the obvious example in Angelman Syndrome is if you expose the children to high attention, so they have attention for 5 minutes with an adult, undiluted attention, and if you then expose the child to a low attention condition for 5 minutes, and you repeat this for a number of periods. So you constantly repeat this to see if you can get a consistent result. And this is the profile that we would expect if the aggression is occurring to gain the attention. So in this condition, we would see very high levels of aggression. And the interesting thing here is the form of aggression that you most commonly see in Angelman syndrome is hair pulling or grabbing of the clothes. But hair pulling is very, very common. And if you want to try this, I suggest you pull the hair of the person in front of you. And when you do that, they will turn around and give you eye contact. I promise you they will do that. And that's precisely the point, because I mentioned earlier on that the eye contact and the social contact is a very strong motivator. So the aggression is not hitting out, which may lead to termination of an interaction. If you pull someone's hair, they tend to stay with you for a little while. And that's exactly what we see when we run the experiment. We see significantly higher proportion of children with Angelman syndrome who show this behavior under that environmental condition than we do children with Cornelia Delange syndrome. So I think that's a good example of a phenotype-environment interaction. So when we go back to our study across the 3 groups, what we now see is a different profile for the Angelman's group than the Cornelia Delange group. And just to go back to the point of early intervention, what that may mean is the advice that we give to parents of children with Angelman syndrome in the very early years gives slightly different emphasis than the advice we would give to children, parents of children with Cornelia Delange syndrome. I just want to pursue this example of unusual motivation in Smith-Magenis syndrome because I think this is one of the problems in Smith-Magenis syndrome that many parents will report, and the manifestation of the behaviour is very different at home than it is in school or any other environment. And there have been a number of reports in Smith-Magenis syndrome of high levels of attention-seeking behaviour. So this means seeking out the attention of usually an adult, although that wasn't documented. And it also appears to be related in the same way as in Angelman syndrome to high levels of aggression. So in this study, we looked at children with Smith-Magenis syndrome and children with Down syndrome, matched them on all the variables that we think are important, and then we looked at, did they seek more attention and were they more vigilant for either other children or adults? And the children with Smith-Magenis syndrome had a significantly higher preference for adult attention over attention from other children. But more importantly, and I realize this is a bit complicated, but more importantly, if you then take children with Down syndrome, children with Smith-Magenis syndrome, and you look at their behavior with regard to their primary carer, in our study the mother, versus an unknown adult carer, then 2 things happened. One was, even if the child with Smith-Magenis syndrome is having attention from an adult, full attention, they will still seek attention from their mother. And if their mother is not there, the child with Smith-Magenis syndrome will not necessarily seek it from an adult they don't know. So this is highly specific. And what it seems to be is that the children with Smith-Magenis have a very strong attachment, and I use the term meaning they are seeking out particular adults in the home environment. And what's interesting is that often the school will say, we just don't have that problem of attention seeking here. We just don't recognise that. But at home, that can be very, very, very significant. When this is combined with two things, high levels of aggression and self-injury, and combined with poor sleeping at night, and the children tend to sleep in the day because of melatonin phase shift, what you then see are the children are awake at night and constantly seeking the attention of adults. And if you measure stress in the parents, the levels of stress in parents of children with Smith-Magenis syndrome is significantly higher than any other parent group. So the point there, I think, is about the specificity of some of that motivational difference. And I just want to finish this point about motivational difference and phenotype-environment interaction by just sharing with you the results of a study of 10 children with autism spectrum disorder in which we looked at what might be an environmental cause. So we did standard experimental functional analysis. We manipulated attention. We manipulated the level of demands in 10 children. We could find no function at all in any of the 10 children. In other words, the standard experimental functional analysis did not make the behaviour change systematically. But if you modify the functional analysis and you now manipulate what you might think of as autism-sensitive events, we found function in 6 children. That was because we manipulated things like escape from sensory stimuli, access to repetitive behaviour. So the point here is that when you manipulate things in the environment, they have to be important to that child and the phenotype of that child for them to become related to the self-injury or the aggression. So the point here is that just as in Smith-Magenis syndrome, you had to manipulate whether it was the mother given access to attention or not. Here you've got to manipulate the environmental events that are critical to that child. So it shows in syndromes and then in autism spectrum disorder how the particular motivation for that child interacts with the environment to drive the development of a behaviour. I've just finished these examples by looking at cognitive difference with some of the implications for autism. So I want to focus on Prader-Willi syndrome and on one behaviour in particular in Prader-Willi syndrome, which many of you will recognise. And this is adherence to routine, which you see in Prader-Willi syndrome, but you do not necessarily see the other repetitive behaviours you see in autism spectrum disorder. And this often goes along with temper outbursts, uncontrollable temper outbursts. So I'll just remind you here of the repetitive behaviours. So on the left is Fragile X syndrome. This is Prader-Willi syndrome. And here you can see this profile of 2 behaviours in particular, adherence to routine and repetitive questioning. And these go together in Prader-Willi syndrome, but the other repetitive behaviours, apart from hoarding, you rarely see in this syndrome. The other problem you see is excessive temper outbursts. This is a poster by a young woman who has Prader-Willi syndrome, describing what happens to her when she experiences this outburst of temper. And this was what we were trying to understand, because the parents' report was that if you interrupted people's routine in an unexpected way, that's what would lead to some of these temper outbursts. Food problems also would, but the disruption to routine was a fairly reliable predictor. So, in terms of building the model, we know the genetic cause, we know something about the behavioural phenotype what we were trying to do then was tie these together and also track a pathway. And that's the story I want to tell you. So the first thing was to look at children's cognitive capacity. So we asked the children to come into a lab setting, sit at a computer, and engage in an attention switching task. So sometimes they have to attend to the colour of an object, other times they attend to the shape. Partway through the experiment, you ask them to shift from attending to colour to attending to shape. When you do that, you measure their reaction time, their time to press a button, and then you can see if they find that easy or difficult. And the story is that when you ask children with Prader-Willi syndrome to shift from attending from colour to shape or shape to colour, their reaction time is much, much slower than children of typical development who are matched for mental age. The important thing here is that this correlated with repetitive questioning and adherence to routine. The children who were slower to switch on a day-to-day basis were more adherent to routine and also repetitively asked more questions. So at this stage, we had what we call a cognitive endophenotype, a cognitive problem that was more common in Prader-Willi syndrome than typical development, but was also correlating with part of the behavioural phenotype as measured in a lab setting. What we were then able to do was to track the sequence of behaviours to show that they were hanging together. So using a lag sequential analysis, watching the children on a day-to-day basis, we could see that when we had the temper outburst, before that, you'd get the repetitive questioning, and we could have sequences in the children. This also allowed us to identify the behaviours that occurred just before the temper outburst, because when we want to experimentally manipulate events, we don't want full-blown outbursts, but if we know there's a reliable behaviour beforehand, then there's less of an ethical concern. So then we go back to the lab, and now we ask the children to do the computer task of attention shift again. And what you see again there is that when they're doing the attention shift task, you start to see those precursors to temper outbursts. If you then have a more socially valid setting, this is playing a game with the children. So you repeat the game with the rules, and then you break the rules. You break the routine. Again, you would see those precursors to the temper outbursts. And finally, the sort of day-to-day event that we'd all recognise. We normally walk home this way from the swimming pool. We're going to change and go a different route. And again, you look for these temper outburst behaviours, exactly what we saw. So what we're able to do now is to show that these behaviours occur when there is an environmental challenge to attention shift, and that interacts with the compromised attention shift to lead to this sequence of behaviours. So again, it's a phenotype-environment interaction. You need both of those things to happen for the behaviours to follow on. But what we haven't done yet is show that this is somehow tied to a physical phenotype or some sort of brain difference. And so this is the final study by Kate Woodcock, and she used functional imaging to look at what happens when people are doing a switching task, which parts of their brain are active, if you like, when they're doing a switching task. And in typical development, you can see lots of activity in the frontal parietal region, which is exactly what you'd expect when people are attention switching. But in the children with Prader-Willi syndrome, you didn't see these same areas of activity. It's much less. So what this showed us is that there appears to be, if you like, a structural reason that there is compromised attention shift. And it's a compromised attention shift that then predicts adherence to routine, predicts repetitive questioning. When the environmental challenge comes in, that cognitive load is much higher for the person with Prader-Willi syndrome than anybody else. It's experienced as much more aversive, and then you see the repetitive questioning, and then you see the temper outburst. What was really important about this study for me was, if you've seen descriptions of children with Prader-Willi syndrome and adults, you will often see them described as obstinate and stubborn. These are very value-laden terms. They assume that someone can do something but will not do it. But I think what we were showing here is that thing that you're asking people to do, it's not because they will not do it, but it's because they cannot do it. And that's a very, very important difference, because then we cannot see people as obstinate and stubborn, but we should see them with a specific cognitive impairment that means that that cognitive demand is much higher. I just want to finish this story by mentioning an interesting emotional difference between two syndromes. So I know this is quite difficult to see, but if you introduce unexpected change to people with Prader-Willi syndrome, you rarely get anxiety, you often get anger and temper outbursts. If you do the same change for people with Fragile X syndrome, you rarely get anger, you frequently get anxiety. And that seems very important to me, because these are not operant behaviours. They are evoked by the environment, but they are not rewarded or controlled by the contingencies in the environment. And that means that operant learning theory cannot necessarily modify these in the way that it could any other behaviour. And it seems to me to indicate something about problems with emotion regulation and a propensity to experience a particular emotion under the same circumstances. And we went back to this to look at people's experience of their temper outbursts, and we found something that I think was really important. So I know you can't see this, but this is one of our doctoral students interviewing people to look at the sequence of the behaviours. And what you see is, early on, you see emotional vocalizations, crying, then you see more angry behaviour, and then you start to see, and that sequence is what you would see in young children of typical development. But the really important difference comes at the end of the outburst, and it's all the way along there. What happens afterwards is people are profoundly apologetic and remorseful about what's happened. And they say, I am sorry, I couldn't control it. And everyone with Prader-Willi syndrome was expressing this remorse at what had happened. And I think that's very significant. In anger, you rarely see remorse afterwards, but in these temper outbursts, people were reporting this change that overcame them. And that, to me, is a very important message there. So, I've described the importance of etiology, how you have these differences across syndromes. We've talked a bit about refining some of the descriptions of psychological and psychiatric disorder, and I've tried to build some causal models. And I just want to finish with, it's just one example, but it's applying a developmental perspective to this, particularly with regard to early intervention and predicting the difficulties that people may have later on. So I go back to Cornelia Delange syndrome. And in this syndrome, when you see the levels of autism spectrum disorder, they start to increase rather than decrease over time. So this is the under 16s with Cornelia Delange. This is the mean total SCQ score, increasing over time. Fragile X syndrome, decreasing. And this pattern was constantly reported to us by parents. These are ADOS results with a follow-up of the Cri du Chat group and the Cornelia Delange group. And there's a follow-up here of about 6 years. No change in most domains, but up the top here, the impaired social interaction is increasing in the Cornelia Delange group and not in the cri du chat group. So in other words, people with Cornelia Delange are experiencing or tripping more of the diagnostic criteria for autism, whether or not it's autism is a different question, but they are changing developmentally as they come into their teenage years and then into early adulthood. And the final part of this story is this. I showed you before that the executive function deficits in this group predicted their social anxiety, but also their performance on some of these executive function domains decreased with age. And in fact, we saw a significant decrease in working memory with age. This is into the 20s. So clearly, one story could be that there is people are experiencing more executive function problems, and this manifests as social anxiety, because you really do, in a social situation, need to inhibit, switch attention, and you need working memory to be able to engage successfully. And these problems are becoming more pronounced in this group. These are very surprised-looking zebrafish there, but the importance is in here is that the zebrafish model of Cornelia Delange syndrome shows problems with neural maintenance. So one possibility is that if there is a similar problem in humans with Cornelia Delange syndrome, that if there is impaired neural maintenance, then it may be that there is a level of neural decline in this group in the teenage and early years. So I'll finish this story with a clinical email that came to me probably about 10 or 15 years ago, before we'd really got into the Cornelia Delange story. And as you read this, many of you will just recognize parts of this. It will feel very familiar to you as a brief story. And I'll just let you read through that. And I want you to look at the parts in yellow. And so 15 years on, after getting this email, I'm always a bit slow with emails, but 15 years on, I think I can sort of see some of the things that was happening. So this young man is becoming 18. So he's entering that high-risk period when we assume his executive function, his ability to cope with the cognitive demands is becoming more compromised. And around that time, he is starting to move from the school environment to a new college environment, and that was overwhelming for him. And you can see there, if things don't go exactly as he expects them to, so some of his insistence on sameness is increasing, probably as a result of the decrease in executive function capacity. And then, if there are unexplained, unpredictable events, he's aggressive. So this feels very similar to the Prader-Willi syndrome story. What happens when he's aggressive? Well, he's removed straight back to home, where everything is predictable again, and his anxiety goes down. And that's a very good learning mechanism. So there you have an interaction between the syndrome, the environment, development, and the cognitive endophenotype for that particular syndrome. So I'll finish by just saying briefly what I think some of the implications are. I just want to emphasize the possibility of pain in non-communicating children. If you're an applied behavior analyst, you know how much work goes into trying to decrease some of these behaviors. But actually, if it is pain, then the interventions are there and readily available. But alongside that, we need accurate assessment, but we also need advocacy. For a number of parents have come back to us saying, I told the doctor he was in pain, but he didn't believe me, and I had to seek another referral. And I think parents are actually very finely attuned to their children's pain signature. Sometimes they need us to help them seek out those kinds of resources. We spent a number of years now looking at, for these very distressing self-injurious aggressive behaviours, can we identify risk markers in the under fives and target those children for intervention at that stage? And we can add to that list, we've always known severity of intellectual disability, we've known autism spectrum disorders. We can now add to that quantifiable risk genetic disorders. I just mentioned this in passing, but we've also identified 2 behavioural markers, even within the genetic disorders, even within the high-risk groups, that predict self-injury and aggression later on. And they are repetitive behaviour for self-injury, impulsivity for aggression, and also health problems as risk markers or causal factors, not sure which. But nevertheless, if I was seeing children under the age of 7, 8, and I noticed some of these risk markers, I think I'd want to keep a much closer eye on that child. Just want to leave you with the idea that I don't want to sort of play down the importance of operant learning theory applied behaviour analysis. It's been a really significant tool for us, very beneficial, good, robust evidence, but it's not the whole story. And I think if we put too much emphasis on that, we might miss other causes, such as pain, for example. We might leave carers feeling responsible for cause and intervention failure when that's not the whole story. And I think that's very important. And we might stifle the development of our extended models. I think we should also think a little bit about choosing the focus of our intervention. So in Smith-Magenis syndrome, if we could address the excessive motivation, in Angelman syndrome, if we address the excessive motivation, you might deal with both the aggression, some of the sleep problems, some of the other difficult behaviours. And in Prader-Willi syndrome, we're trying to develop ways of teaching the children or helping the children to attention switch. We're trying to see if cognitive games will increase that capacity. We're also using some very straightforward cueing procedures of cueing unexpected change to make it expected. So there are a number of things that we can do where we're not now dealing with the behaviour that's downstream from the motivational or cognitive endophenotype, but dealing with that motivational and cognitive endophenotype itself. That's some way down the line, but I think it's important to start thinking about that. Last thing I'll say is a quote from an Elvis Presley song, and it's before you judge me, you take a walk in my shoes. And it's really about people with Prader-Willi syndrome being referred to as obstinate and stubborn. And I think it's important that if we had that similar problem with our attention shift, then we may feel equally put upon by what appear to be very reasonable demands from our environment. We have some resources that I'm happy to send to you. These are summary papers. This one is about 3 or 4 pages long. So it's just a quick summary of self-injury information. If you email me, I'm happy to send that to you. This is written for parents about self-injury. It's a bit long, but we have both long and short version. We can send you PDFs of that. Please send it around. We're currently developing a new website together with 6 or 7 different syndrome groups, and we'll be releasing this throughout the coming year. It's called FIND, which is Further Informed Neurodevelopmental Disorders. And each syndrome will be featured on there. There are parents speaking about their experience. There's videos of children showing difficult behaviours, videos of intervention, videos of assessment, and so on. So I'll stop there and thank you for your attention. This is a group of people who get their hair pulled. And as they do that, then I can come to Stockholm for a couple of days. So it seems to work out pretty well for me. Thank you very much.